So there's a number of different de-escalation strategies that are of interest to try and optimize oncologic control with treatment-related toxicity. Some of those more notable ones include de-escalating adjuvant therapy following minimally invasive surgery such as TORS, risk and response adaptive de-escalation as we've done in a number of our studies, and of course trying to replace cisplatin with other types of concurrent regimens. All of these are being investigated. Of course, many of these have been limited to either single-arm phase 2 studies, and so really need to be evaluated in a randomized setting to be incorporated in terms of standard of care. We also saw a lot of this meeting and previous meetings looking at novel biomarkers to improve both grading treatment response and surveillance. So an example for that with oropharynx cancers is cell-free HPV DNA, which can detect and quantify HPV DNA in plasma and seems to be a quite sensitive and specific marker both of grading treatment response as well as monitoring for recurrent disease. And so the hope will be that we'll be able to incorporate these into our treatment paradigms to optimize treatment care, both in terms of oncologic control as well as treatment-related toxicity. And then in terms of the recurrent metastatic setting, there's a number of advances beyond anti-PD-1 that I think are of interest. There's a number of strategies to develop HPV-specific immunotherapy and a number of targeted therapies as well that are quite promising, and novel combinations, of course, as well. So I think the future is bright, but of course we await these exciting results so that we can bring these to patients and see if there's a true survival as well as quality of life benefit for patients.